Good afternoon and welcome to today's webinar. My name is Carrie Brill and I'm a caregiver specialist at Fairfax Area Agency on Aging. It is my pleasure to welcome our presenter, Marcy Fairbanks, who will be leading us in an overview of hospice and palliative care. For your future reference, you should have received Marcy's slides via email this morning. Please note that you will not need to have the slides open during the presentation, as you'll be able to see everything on your screens. Should you have any questions, you may type those into the questions section at the bottom of your panel at any time. We will have time to answer the questions after the presentation. Today's webinar is being recorded. We will email this recording to all participants early next week. At the end of today's presentation, you will be asked to complete a brief survey before you sign out. Your participation in the survey would be greatly appreciated, and we welcome any feedback and/or suggestions that you may have. Now, it is my pleasure to introduce our speaker, Marcy Fairbanks. Marcy is a licensed clinical social worker and has been a hospice champion for 20 years. She believes that the holistic approach to hospice care makes all the difference in the lives of those with a life-limiting illness. Throughout the year, she has served in numerous capacities and is currently the Director of Family Services at Capital Caring Health. In this role, she functions as an advocate for social workers, chaplains, grief counselors, with the primary focus aimed at developing dynamic programs that enhance patient and family experiences at end of life. Her dynamic personality and passionate quest to raise the bar on services rendered by hospice staff make Marcy a leader in her field. Those that know her would tell you that she is highly creative and driven towards positive outcomes. Additionally, Marcy acts as an adjunct faculty at James Madison University, where she teaches undergraduate students about the importance of hospice and palliative care. The classroom is a natural setting for Marcy, as she uses her dramatic flair to bring the world of death and dying to life for her students. Outside of her work, Marcy enjoys a quiet farm life with her husband and 4 children. She spends her free time attending her children's functions and tending to the needs of quite a few variety of animals on her farm. With that, join me in once again welcoming and thanking Marcy for joining and sharing her knowledge and experience with us today. We look forward to hearing from you now.
Thank you, Carrie. I appreciate the introduction, and I'm honored to be here with you all today. And I appreciate your participation in today's overview of hospice and palliative care, which I think, if we really consider it, is perfectly timed, given the crisis that we are in the throes of with the COVID-19 pandemic. If there's anything that has been illustrated by this experience through this pandemic, it's the importance of each of us being informed and educated about our options that might impact our ability and our goals of care when it comes to potential end-of-life decisions that we need to make, not only for ourselves, but also for our family and friends. So today, I hope you'll join with me in taking this deep dive into the world of hospice and palliative care. It may not be something that is always top on our mind in terms of learning new things about, but I am hoping that you're going to be able to come away from today's experience equipped with additional information that will help guide you as you navigate difficult decisions moving forward. So without further ado, let's get into our PowerPoint and our objectives. For today, the purpose is really to demonstrate an increased level of understanding about palliative care services, which are also known as advanced illness services. So we're going to talk about eligibility requirements, insurance benefits, and the specific nature of the services that are offered. And then we're going to go into the world of hospice services, because oftentimes people do think that they are synonymous when there are very different programs. So we're going to talk about hospice eligibility criteria, what kind of insurance coverage and payment options are available to individuals, what kind of specialized programming is possible, as well as the core services and optional services. So those are the key objectives from our presentation today. So we're going to start with a discussion related to advanced illness and palliative care. Advanced illness and palliative care are synonymous terms. So I will be using them interchangeably throughout the presentation. So what is advanced illness care? And what is palliative care? I'm sure many of you, if you think about it, you've heard the term palliative, and you might actually have some thoughts that come to mind. And if we had time, I would certainly be interested in understanding what your preliminary thoughts were on this program, and then seeing how we could compare them at the end and the conclusion of our webinar today. But for the sake of our time, I really want us to dive deep into this program specifically and help you to understand that the primary goal of the palliative care model of care is to prevent and relieve suffering and to improve quality of life. So all of the program developments and all of the eligibility criteria are really geared around meeting that fundamental goal. So how is that done? Well, first off, I want you to understand that palliative care as a program is really geared towards symptom management. Sometimes it is specifically related to pain, but not always. Oftentimes individuals think that palliative is only about managing pain, and it is not that. Palliative services are not the same as going to a pain clinic. Okay, so I want to be very clear about differentiating that. Palliative care is really about pain and symptom management that are related to the primary serious illness. And this slide demonstrates some of the examples of what kind of illnesses are typical, you know, in terms of individuals accessing palliative services. So if you have a cancer diagnosis, and it can be a variety, it can be any type of cancer diagnosis. It could be any kind of heart disease diagnosis, a pulmonary disease, neurological diseases, which could include ALS, Lou Gehrig's disease, Parkinson's, Alzheimer's, stroke. You know, the list, this is not a comprehensive list. This is just kind of what we commonly see in the palliative world. And it could also be including kidney diseases or those with liver diseases. So what I'm trying to stress about this is it's not necessarily the disease that brings you into palliative care, it's the management of the symptoms related to those diseases. You know, having cancer in and of itself may not necessitate inclusion in a palliative program. However, if you have a cancer diagnosis, for example, say you have a breast cancer diagnosis and you are undergoing chemotherapy treatment. Sometimes one of the side effects of chemotherapy treatments could be anemia. And with anemia comes a whole host of symptoms that can be very debilitating, one of which is excessive fatigue. You could have nausea. You could have sleep, disruptions. So palliative services would be geared towards trying to address those symptoms while you're still participating and engaging in the curative treatment options. So you don't have to make a choice. You can have both at the same time. So some typical symptoms that are managed through the palliative program are just what I gave the example of. It could be nausea or vomiting. It could be fatigue that's excessive to where it's so debilitating you just can't function and it impairs your quality of life. It could be breathing difficulties. As with anemia, the example I just gave, shortness of breath can be a hallmark symbol and sign that someone is suffering with debilitating anemia. Constipation, loss of appetite, pain, like I indicated. So these are just some examples of the symptoms that the palliative care team is going to try to address and improve upon within the services that they are providing. And it's important to note that some of these side effects that are really the goal of treatment from a palliative perspective may in fact be side effects of the actual curative interventions that individuals are undertaking, okay? But I want to make it clear that, you don't have to have a terminal diagnosis in order to be able to access palliative care services. And that is a very important distinction for people to understand. So eligibility is to anyone of any age who's suffering what is called a progressive illness or a chronic illness. So you don't have to have any age guidelines, and there's no guidelines with regard to, the specific nature of the disease. It just has to be progressive. And progressive illnesses are considered to be those illnesses that may get worse over time. So keep that in mind as you're contemplating whether the palliative program might be a good program for you or a loved one or a family member or a friend. So it is available, and it is not dependent upon whether or not your condition can be cured. So I want to stress that and reiterate that one more time. Just because you are undertaking a treatment that is aimed at curing your disease process, if in fact your disease is not cured from it, that does not mean that you cannot access palliative care services, okay? So this is important because research has demonstrated that palliative care services for individuals who are with progressive illness, it's actually been proven to improve the quality of life of that individual, in addition to relieving those symptoms. And that's really the hallmark goal, is to improve the quality of life. And it's not based upon any anticipated life expectancy. So that is not an eligibility criteria. And so it's important also to remember that these patients can receive medical care for their symptoms while they're also receiving curative treatment options, okay? And one of the other great benefits of participating in a palliative care program is that your team, and we'll talk about the team members in just a moment, are really going to help you individualize your goals of care. So those dedicated conversations by your team members are going to help you have a greater understanding about what kind of choices and decisions you might make when presented with perhaps a change in your medical circumstances moving forward. So on to the next slide, I'd like to kind of cover some of the frequently asked questions. And one of the common points that I really want you to understand too is who provides the services, because this is important. Who is it that's part of this care team that I'm talking about? The care team for Capital Caring Health is made up of nurse practitioners, but I want to make it clear that there are palliative care programs that offer other options as well. So to make sure that you have a breadth of information, not just restrictive to what our organization offers, I want you to also understand that some palliative care programs do offer nutritionists, chaplains, and social workers who are participating in the care team. So another question that comes up is, if I participate in this palliative care program, do I have to give up on my primary doctor? Because many individuals have really cultivated a really wonderful relationship with their primary care doctor. And so it would feel very uncomfortable to think about giving that relationship up. And I want to assure you that you do not have to make a choice with answering that question in order to participate. In fact, your advanced illness care team works with your doctor and works with other care providers so that there's greater continuity of care. So if something is changing and you're responding to a certain medication in a certain way, that's being communicated, and your palliative care team is helping to develop those collaborative conversations so that there's greater access and continuity of care across your service providers. So that's another enhancement to participation. So then the question is, where are these services offered? Services are provided in the care setting of the individual. So whatever your primary residence is, whether it's in your home, whether it's in the hospital at that moment in time, whether it's in a long-term care facility, or even an assisted living facility. And there are other care setting options as well, but it's really wherever your primary residence is where these palliative care services would take place. So then the one question everyone wants to know about is who pays for palliative care? And that's a very legitimate question. You know, whenever you're undertaking an additional layer of care, you want to understand how that's going to impact your pocketbook. That's vital. And often it can be the point that's going to help you make a decision about whether or not you can access the service. So palliative care services are typically covered by Medicare Part B, and some Medicaid programs offer palliative care coverage as well. And in addition, many commercial healthcare plans also offer palliative care coverage. They do have associated deductibles or out-of-pocket costs. So I would encourage you to ensure your understanding of what the specific coverage is for you and your commercial health plan, if that's the case, or even your Medicaid program, just to make sure that you're not blindsided by any unforeseen expenses down the road. So that's always a good conversation just to have with your healthcare agency to verify the accuracy of your coverage plan. And then veterans also are eligible for this service through the Department of Veterans Affairs. So if someone is service connected through the Veterans Affairs Department, then they should have access to palliative care coverage as well. So some individuals often think, well, if I'm participating in palliative care, does this mean that I'm dying? And that's a legitimate question. You know, and I want to assure you that you don't have to have a terminal diagnosis in order to participate in palliative care. And many patients will enter into the services of the palliative care program and then actually see improvement in their symptoms, which improves their quality of life and improves their symptoms to such an extent that they may not actually need the palliative care services any longer. It could just be that they just needed them for that point in time to help them to work through whatever symptoms were related to the treatment that they were receiving or to the disease process at that point in time. But I do want to assure you, you do not have to have a terminal diagnosis in order to access palliative care services. Okay, so that is kind of the palliative care program in a nutshell. It is based upon, like I said before, the goal of improving quality of life and helping relieve symptoms to promote comfort. You know, and that's really the root of the term palliation anyway. So that's what I have for the palliative care program. And I really want to spend a lot of time talking about hospice services and helping individuals understand, like I said at the beginning, what the difference is between the two programs so that each person can make an informed decision that's best for them. So jumping into the hospice program, you know, it's important to talk about the eligibility criteria because they're different than with the palliative care program. You know, the one thing that is similar though is that hospice programs are available to anyone at any age. It is sad to think about, but it is important to understand that hospice programs serve infants to, I think our oldest client that we had was 102. So anyone who meets the terminal criteria is eligible for participation in the hospice program. You know, and they really do need to have that terminal diagnosis, and that life-limiting illness needs to be determined by their primary physician and then also by a hospice physician. So there has to be what's called a certificate of terminal illness. And so that's where you probably heard the terminology of 6 months or less in terms of the criteria. And that is a true statement. Oftentimes, physicians are trying to answer that question. You know, do I expect that my patient is going to have 6 months or less with this disease process, given the trajectory of illness that they're experiencing up until this point? And if the answer to that question is yes, then they can refer an individual to the hospice program. But I do want to make it clear too that anyone can self-refer to a hospice program. And then the hospice care referral team can do an assessment to determine if you are in fact eligible. So the referral to the program does not specifically or necessarily have to come from a provider, but we do get additional background information from the provider. And even if it's a self-referral, we do need to have the provider attest to the certificate of terminal illness for the diagnosis that qualifies the individual for hospice participation. So I just want to make that clear, okay? So the other additional eligibility criteria is that individuals need to understand that maybe at this point in time, you're willing to forego any treatment or interventions that are aimed at prolonging life. So we see it lots of times in the hospice world. You know, a patient has been receiving multiple rounds of radiation, multiple rounds of chemotherapy, as well as other kinds of therapies to help manage their disease process. And then it might come a point in time where the symptoms related to the treatments themselves are debilitating. And they have to make a choice. Do I want to continue with these curative treatment options that are not improving my quality of life and are actually functionally debilitating me to the point where I really don't derive the joy and pleasure in life that I did before? And so that's a tough decision for patients and families to try to make. And so we really rally around families in helping make a decision that's best for them. And it's really about having those goals of care conversations. You know, when an individual is diagnosed with a life-limiting illness, it's important to talk with providers about what that trajectory of illness might be. What kind of treatment options might need to be considered, and what the outcomes are that the patient desires, because everyone has individual goals. Everyone has individual ways of giving value to life. You know, I've heard it said from many individuals, you know, if I'm not able to communicate with my loved one anymore, then that signifies a very unfortunate quality of life for me, and that's just not a place I want to be in. And so that might be the point in time where, you know, a hospice consideration might need to be made. That's just one hypothetical example. There's countless others. But it's important to recognize that individuals who do participate in hospice programming, you know, are really patients and families that are looking for the specialized end-of-life care that incorporates the holistic model of care. And what I mean by that is members or participants who engage in hospice, we're providing psychological, emotional, spiritual, and physical support alongside with any kind of necessary medical treatment options to reduce symptoms and promote comfort. And that's important to understand, because we recognize that when an individual is diagnosed with a life-limiting illness, it affects the whole person. It affects the whole family system. And so we rally around that family, we rally around that individual to help them with whatever realm of concern they might have. You know, if you think about having a cancer diagnosis and how does that impact you emotionally, and how does that impact you spiritually, you know, and how does that impact you socially in terms of your family unit and your friends. So really addressing that, and we're going to talk more about that when we get into the core team structure, is important because we're supporting the whole person. We're really, I always liken it to, we're the arms wrapped around the family with the patient at the center. We're helping orient everyone around the patient's goals of care. And if they haven't been clearly defined, then we're working with them to help define those goals of care and then rally everyone around supporting the individual towards that end. So that's important to consider too. So there are lots of potential diagnoses that would qualify an individual for hospice. These are just some of the most common, you know, which are very similar to those that qualify individuals for the palliative care program as well. I just wanted to list them up here just so that you could be familiar with what those different options are. So again, whenever you're considering adding in another layer of support to meet your needs, you also have to consider the payment source. And I am very happy to announce that many, many years ago, the federal government recognized that hospice should be something that everyone has access to. And so patients with Medicare Part A can automatically start hospice care when they elect the hospice Medicare benefit. And with that, there's no additional cost. So it's covered at 100% when electing the hospice Medicare benefit. And there are a lot of different services that are included in that, and it's very fulfilling to recognize that this is accessible to so many individuals through this hospice Medicare benefit. And to not get a bill for it, that's even better. But then also those with Medicaid as their primary coverage can also elect the Medicaid hospice benefit. Not all state Medicaid programs cover hospice services, so it is important to verify whatever state you are living in, whether your Medicaid benefit covers hospice. So just wanting to point that out. And then if you have other types of private insurance, there's usually a hospice coverage to each commercial types of insurance. But it is important, and it is best practice to check with your individual plan or even your employer so that you fully understand the costs and the specifics of what that coverage is for you. And then if you don't have health insurance, we at Capital Caring Health have patient care funds because we want to ensure that no one is denied access to end-of-life care. And so we are proud to have a program that allows hospice coverage to anyone regardless of their ability to pay. So if that is ever a concern, that's definitely something to talk about with a referral specialist. And I know a lot of different hospice programs, within the tri-state area have similar patient care fund opportunities that could be explored, okay? So one other thing I think is important to understand that was similar to palliative, the palliative care program, is where these services are provided. And again, it's wherever you call home. It could be your primary residence. We've had services that we've provided to homeless individuals. We've had individuals who are living in tents, and our hospice care team goes to where they are. And we do our best to try to meet the patient's needs in the environment that they're living in. And then we also, of course, provide these services in assisted living facilities, in nursing home facilities, and we also have inpatient care centers. A lot of times people aren't aware that we have these inpatient care centers, and we're real proud at Capital Caring Health that we have 4 of them currently available to really help manage those symptoms that for whatever reason are not responding to the suggested treatment options. And so as an alternative to going to the hospital, those individuals could transfer into one of our, we call them IPUs, to be able to get their symptom under control before either discharging back to their primary residence or in some instances remaining in our inpatient unit through the end of life. So that's important to understand. And I think it's also important to clarify one thing related to where hospice care is provided, because I think there's a misconception related to hospice care. And I've heard it said over and over again, well, I don't want to go to hospice, as if signing into hospice means you have to leave your home and go somewhere else. And I want to assure you that that is not the case. As I've already indicated, our hospice services are provided in your primary residence. That is not to say there are not some individuals who do admit directly into hospice care into one of the inpatient units because of symptom management issues, but that is not a requirement. Okay, so I want to stress the importance that you don't have to leave your home in order to access hospice. We come to you. Okay, so our next slide addresses the variability of hospice services. You know, my lens, of course, is through the world of the services that we are providing in my current hospice, but I've also worked at other hospices. And so it's important for you to understand how some of these different programs vary, and how that might impact you in making a decision about which hospice is best for you. However, one fundamental characteristic is the specialized core team that's designed to help you. And that's really made up of the disciplines that are indicated on this slide. And I am going to dedicate more specific time to talking through each of those roles in an additional slide. But I also want you to understand that hospice services are available 24/7. What that means is that our on-call staff are available to answer the phone and either send a nurse out to attend to the medical condition that you're experiencing, or to advise how to treat those symptoms via that telephone contact. What I want to stress, and what has also been a misconception, is our staff are not in your home 24/7, okay? And I think that's an important distinction to make. We are available 24/7. If you ever needed 24/7 care, we could certainly send you information about resources in the community that could support you in that endeavor, but our team does not provide 24/7 care, okay? But what I do think is important to note is that under the hospice Medicare benefit, that covers at 100% not only your core team services and the on-call support, but it also covers your medical equipment. The equipment such as wheelchairs, hospital beds, oxygen in your home, and any kind of medical supplies that are important for your care team to be able to have available to them in taking care of you. So if you have a primary diagnosis that includes wound care, then those wound care supplies would also be covered under your hospice Medicare benefit, okay? So that is important to note as well, because oftentimes people will see a reduction in some of their outgoing expenses because hospice coverage from the insurance perspective is going to pick up the tab even on your medications to help control your symptoms related to your primary diagnosis. You know, there is discussion upon admission into hospice where the provider will review your medications and then determine which ones are covered and which ones are not. And that's really based upon what your primary diagnosis is that allows you to be eligible for the Medicare hospice benefit, okay? So, but you also have access to some other services, some of which include nutritional counseling, physical, occupational, or speech therapy as needed. And there could be short-term care in, like I said, one of our IPU facilities if it's medically necessary. So if you're having symptoms that need to be managed more effectively, we call that GIP. So you might actually be eligible to have that covered through your hospice benefit. And the same goes, we have GIP beds in various hospital settings too, to help address your symptoms and get them under control. And those kind of stays might be covered through your hospice benefit. But an additional feature that a lot of individuals are not aware of is that built into the Medicare regulation is that short-term respite care, which is up to 5 days in a facility, is also covered. And this is really used when there might be some caregiver issues. You know, we all know if we've ever done any kind of caregiving that it takes a toll on our health too. And so one thing that you don't have to decide is whether you can take care of yourself while also caring for your loved one if you have the additional support offered by hospice, because this respite benefit will allow you to tend to yourself for up to 5 days, whether it be to, you know, get a medical procedure done, or if you already had a scheduled vacation that you'd already prepaid for, you know, then up to 5 days would be covered and you could still access that. So that's definitely something to talk to your primary care team about so that we can help facilitate getting the arrangements made. And in addition to the core services, there's also grief counseling support, and we'll talk a lot more about that in a future slide. But I know one thing that we're real proud to offer here at Capital Caring Health is tuck-in calls multiple times a week from our volunteers just to check in, just to see how you're doing and see if you have any kind of needs that need to be addressed, to help link you to the resources within our organization that are going to help you get your needs met. Okay, so this is kind of a summary of some of how hospice services can vary, and it's important to understand if you're considering hospice that you understand what the hospice you're considering is actually able to offer. So as I mentioned before, I'm going to talk a little bit more extensively about the core services. Nursing, of course, is very important. The nurse is going to develop a visit frequency to come out and visit you dependent upon your needs. You know, initially the nurse is going to come out and do a head-to-toe assessment just to kind of get the baseline in terms of your symptoms and what our plan is going to be in terms of how we're going to address that. And then they're going to change their visit frequency to respond to you. You know, one of the hallmarks of hospice is that we want you to be your best self, and we want you to live your life as fully as possible. So if you have the opportunity to do something that's going to be really a boost to your morale and is something that you're looking forward to, and you have a scheduled visit with one of our core service members, we always encourage people, you know, just reschedule and do for you what needs to be done so that you can have that enhanced quality of life experience. And that's important. You know, we don't ever want you to feel like just because you join in with hospice, that means you're bound to our schedule. We really accommodate you, and we build our schedule around meeting your needs. So that's an important distinction that I want you to take away as well. You know, so as I spoke about before, our hospice services are based upon this holistic model. And so social work is a core component of the hospice team. It's not optional. Social workers are assigned to each patient that comes on board because we're there to help link you to community-based resources, help assess your needs, and help you develop a plan for how you're going to navigate increasing caregiving needs as your condition changes over time. We're also there to provide emotional support and that anticipatory grief counseling that is really, really important, not only for you as the individual experiencing the life-limiting illness, but also to the family that is supporting you through this journey. And the social workers are really well trained to guide families and help support people through the very conflicting emotions that are tantamount to end of life, you know, the end of life process. So keep that in mind. And then we also have home health aides or CNAs, certified nursing assistants. Those terms are used the same. And these are trained professionals who can come into the patient's home and offer bathing services. So they can do shaving for men, they can do you know, grooming, lotioning on the legs, helping with personal care needs, changing the sheets on the bed while they're there. So their service is invaluable, not only for the patient's comfort, but also to the relief of the caregivers, to at least have some extra support coming in to assist with some of those tasks, which can be daunting or even impossible, you know, depending upon the medical condition that the caregiver themselves might have. And then we also offer chaplaincy, because in recognition of the holistic model, we understand that regardless of your religious beliefs or spiritual beliefs that you might have had throughout the course of your life, when you're confronted with a life-limiting illness, sometimes we really have some, I call it an existential crisis, where we might really grapple with the truth of what we've known or doubting our future moving forward. And so our chaplains are non-denominational, and offered and available to offer support regardless of how you define spirituality. And I want to make that really clear. You don't have to have any faith base in order to get benefit from a chaplain's comforting presence. And that's really what it's all about. And then we also have nurse practitioners, and we also have providers. We have physicians who are supervising the team. So those are the core services that comprise the hospice care team. And like I said, the visit frequency for any of these disciplines is really contingent upon the care needs of the patient. And then our core staff are going to respond to those care needs over time. So there might be some instances where you might see more or less of some of these different disciplines, depending upon what the patient and the family unit is experiencing, okay? So then we also have additional service options. We have hundreds and hundreds of dedicated volunteers. And truly, we would not be a hospice organization without the backbone of our volunteers who serve in a variety of capacities. At this interval, due to the COVID-19 pandemic, we are offering volunteer visits conducted virtually. The same with some of our core services. Like social work and chaplains, we're doing those through Zoom and also through telephone because we recognize that patients and families might struggle with the idea of having additional staff members coming into their home at this point. And then all staff who do enter into the home are fully equipped with proper PPE, and we do COVID screens on a regular basis to ensure everyone's safety. So I do just want to point out that we have had a service change with the volunteer component because volunteers are not making in-person visits at this juncture, okay? But some of the other additional service options are, like I mentioned before, some of the therapies, which could include dietary or nutritional counseling, and that does have to be ordered by our provider in order to, gauge how frequently these different disciplines would actually participate in service, but that can be arranged if it would be beneficial. And then we also offer grief counselors to offer support. And I want to spend a little bit of time talking about our grief support program. Grief support services are required by Medicare. It is a service that is required, but defined very differently across different hospice organizations. So many offer services to anyone in the community who has experienced the death of a loved one, not just specifically to those who have had a loss of a family member who has experienced the hospice services specifically. At Capital Caring Health, we do that. We do a lot of outreach in the community. If there's been a loss, due to the COVID pandemic, we've received an influx of need during this difficult time. And I just want you to know we're here to support people at no charge. So we're very excited that our services are available to that extent. And we offer individual counseling, which is considered short-term. We are not trained mental health therapists, so it is different from accessing mental health therapy. Our counseling services are geared towards grief support. And so psychotherapy would be left to the mental health therapists. And if it's something that's more related to the loss of your loved one, then that's where our area of expertise comes in. And our grief counseling support staff are very well trained. Many of them are LCSWs, such as myself. Others are masters in divinity. We have, art therapists on staff, all geared to help support anyone at any age in their grief journey. So like I said, we have individual sessions, but we also offer a variety of support groups and workshops. And again, due to the COVID-19 pandemic, we are doing all of our grief support virtually. So we use the Zoom platform, and we also use telephone support to help link individuals to what they need. And we have specialized programs that are dedicated to offering individualized programs for children and adolescents. So you could always check it out on our website if you're interested in learning more about some of the different programs that we offer. Okay, so But I will stress there's no charge for any of our programs. So whether it's individual, support groups, or workshops, there's absolutely no charge for any of those services that we provide. So that I kind of ran through a lot of the different functionalities of both the hospice and the palliative care program. And I want to spend a couple of minutes before we get to questions, just debunking some myths that people have about both hospice and palliative care. Because I think when you have a lot of misconceptions about what the programs are, then that can actually act as a barrier to having individuals access services that could be life-altering in a very positive way. So one myth that I'm very common, and I'm sure you all are familiar with it, is the idea that palliative and hospice care are synonymous, that they are one and the same. And I'm hoping now that you've heard my webinar so far that you understand some of the distinctions between the two programs so that you can be more educated and informed as you talk to your family and friends, and helping them understand that to access palliative care, you don't have to be terminal. You don't have to be experiencing a life-limiting illness. And conversely, having hospice care does not necessarily mean that you're going to die this week or this day. A lot of individuals have a lot of fear that once their primary care physician has referred them to hospice, then that just means they are done for, that there's no hope. And I want to assure you that accessing palliative or hospice care services actually brings a lot of hope to the circumstance. It actually generates an improved quality of life for individuals, and research has demonstrated it actually improves and increases the length of life expectancy as well. So I want to let you know that when an individual, even though the primary care physician says and attests to 6 months or less, we have had hospice patients on service for much longer, and we have actually discharged patients because they no longer meet the hospice criteria. So we call it graduation. So I want to let you know that there is a bright light that comes with participation in both hospice and palliative care programming. It enhances quality of life, not only for the patient, but also for the caregivers who are tending to that patient, to help offer resources to them that are going to help them be able to navigate the road that lays ahead. So I just want to clarify that. That's one myth that, you know, is very important to distinguish between. But the other one, again, and this is reiterated by what I just said, is that the term palliative means I'm dying. That means I'm dying. It's over. And when you have that mentality, it really shifts the focus from living to dying. And what we want to do with the support that's offered through hospice and palliative care is really shift the focus from dying to living. Because regardless of the length of life that someone has remaining, there's a lot of life that can be lived in that time. And our team, our care teams, are to help support individuals in maximizing their potential for whatever life expectancy they have moving forward. You know, and the term palliative actually means to cloak or to protect. And from a medical standpoint, we translate that into alleviating suffering caused by a serious illness. And that's really what we're all about, whether you're accessing a palliative care program or a hospice care program. We are aimed at relieving your suffering, okay? And then one thing that I really want to point out too from a myth perspective is that palliative care and hospice care hastens death with the use of morphine. And this is a myth that a lot of individuals talk about and are fearful of, and it's very understandable. You know, I want to reiterate though that that is definitely not the case. I've been in hospice for 20 years, and I've heard many individuals express fear specifically related to this. I don't want to join in or sign up with a hospice program because they're going to give me morphine and I'm going to die. And I want to assure you that morphine is a commonly used medication that helps to relieve breathing difficulties as well as pain. It's a very inexpensive medication that's given. That's why you hear morphine used with hospice patients on a regular basis, because it does a good job. But what we do not do is give doses that are lethal. One of the hallmarks of hospice care with any medication, and you can talk to any provider about this, is that we titrate doses. So we incrementally increase them in order to be able to relieve the pain and suffering that the patient is experiencing. So we are very thoughtful. Our providers are extremely thoughtful and intentional about prescribing medications, whether it be morphine or other opiates, with the only goal being that we are trying to relieve your symptoms so that you can be comfortable. So those are some of the key myths that I hope I have effectively debunked today at the coming time of the end of our webinar. And so I want to open it up to questions if anyone has any. Carrie, I'm not sure if any questions have come in through the chat box, but this is a great time for us to be able to address any questions that you might have at this point.
Okay, yes, I do believe we have a few questions. Thank you so much, Marcy. You just gave us so much great information during this presentation. And the question I have now is, can a family member or the patient reach out directly to hospice if a physician has not made a referral?
Yes, individuals can self-refer. We've had patients call specifically. We've also had family and friends call. And what happens is they'll call into the referral desk, and the referral intake individuals will get specific information. They'll want medical history information. They might need to get information from providers to confirm diagnoses and or treatments that have been given. And then they might schedule an initial assessment in order to determine whether or not the individual is in fact eligible for hospice services. So yes, people can self-refer. We just need to have the corroboration of the physician to verify the individual's eligibility. Great question.
Great. Another question is, how does knowing a prognosis will affect a patient's decision about a medical treatment?
Can you repeat that question? I just want to make sure I understand it fully.
It says, how does knowing a prognosis will affect a patient's decision about a medical treatment?
Well, there's probably lots of different examples of that. If from a prognosis standpoint, if we're talking about hospice services, it's important because the individual might say, you know what, after talking with my physician and understanding that at this point in time, my condition is not responding to these treatments, and at this point, they're expecting that I have a 6 months or less prognosis, then I might not want to continue with perhaps the radiation or the chemotherapy treatment options because it's not yielding the benefit that we were hoping would come from the interventions. And I think one of the things that's important to consider is the impact on those treatments to the patient. And sometimes the actual treatment options can cause a lot of physical debilitation and symptoms that reduce an individual's quality of life. And so it can become a quality of life issue as you're trying to weigh out, do I continue with this curative treatment measure when my physician is already demonstrating that it's not going to cure my condition? And do I want instead to focus on whatever life I have left and spending it with the highest quality of life in the way that I want it to be with, whether that be with family or friends, however you define quality of life. Sometimes making that decision to forego those interventions can allow individuals to more clearly live out their life the way they would want to.
Okay, great. Thank you. One other question is, when is the best time to actually start talking and asking whether it's your primary physician or someone about palliative care, if you're heading that direction, or hospice care? And example is, I have an elderly mother-in-law who's 100 who lives with me, and she's got some dementia going on, and there's some stuff that's going on there. But at what point do you think, gosh, maybe I should really call someone about this?
Yeah, and that's a great question, because oftentimes people don't seek out these services, and then they may be brought in at the 11th hour, and then it's a little too late to get the benefit from the program. So the rule of thumb that we always try to get out there to people is, as soon as you're diagnosed with something, a serious condition like the list that I had presented before, or even age, if you have Alzheimer's and you're having functional debilitation, that might be a time to do a palliative care consult. There's no harm in consulting with a program to see if there's a way that they could help assist in managing whatever symptoms you're experiencing. Does that make sense?
Yes, no, that absolutely makes a lot of sense. That's very good. Let's see, I think we probably have time for just a couple more questions here, but I know we're wrapping into that 1 o'clock hour we're supposed to finish. And let me just wrap up so that for those of you that have joined us today, that you can hop off if you need to. This, again, it will be recorded, so you'll get it sent out to you early next week, and you'll have a chance to review what you may have missed. But I want to give all of you plenty of time to ask questions that you may want to ask. And Marcy said she's willing to hang on just a little extra if we need to. So as we wrap up, just to let you know, there is a brief survey as you sign out. Let us know if you have any topics you would like to see presented in future webinars. We do have 4 more webinars scheduled for this year. Our next webinar will be discussing caregiver stress and healthy living. It will be on Wednesday, August the 12th, beginning at noon, so I hope you'll be able to join us then. Marcy, again, the information you provided today was so insightful, and I know it was very helpful for everyone listening and all of our caregivers. I just want to thank you so much for your time, your expertise this afternoon. And I'd also like to thank all of the caregivers that popped in, and those of you that are joining us this afternoon to take part of this, and for listening. But if you do have questions, or you think of something after today and you still want to reach out to Marcy, she's more than happy to hear from you. And just so you know, you can email her at mfairbanks, and that's MF, both capitalized, AIRBANKS, at capitalcaring.org. So we look forward, just so you all know, to reviewing your surveys and getting any comments you may be offering for us. And we thank you for spending time with us this afternoon, and hope to see you again on August the 12th. So for those of you who can remain on, we can finish up any questions. I'll be looking back at the questions box to see if we have some more questions. Let's see here. I'm curious, Marcy, how did you end up getting into this field?
Yeah, that's a great question. I had an experience. My mother was in hospice care, and it was a very traumatic experience. She wasn't in this area, and I think it just really brought to mind the importance of advocating for the best quality of life experience at end of life, and offering choices to people. I saw it in her experience that, it was really hard to know when an individual could make their own choice about medical interventions, whether they wanted them or not, and it impacted her ability to be able to really die the way that she wanted to. Because I think a lot of individuals feel very pressured by their provider, and so then I really felt strongly that it was important to advocate that we all have the ability to ask questions, and we deserve answers. And through the process of questioning and answering with our providers and our families and ourselves, we're able to develop a plan for how we want our end of life experience to be. And if we're fortunate enough to have the gift of time to make those kind of decisions for ourselves, then I have noticed and seen firsthand that the family response after the death of their loved one is so much more peaceful. So that's kind of it in a nutshell. I could go on and on about it, but it's really about promoting advocacy and helping people make a decision that's best for them.
That's great. Thank you for sharing that. I know we too have experienced having hospice in family care. And I think one of the things that I remember the most was the follow-up. My father-in-law was very, very sick. He was at home, ended up in the hospital, and they ended up taking him to a hospice care center. And he was there very briefly, but the love and care that we experienced, not just during that moment, but for years, they would make phone calls to us just to check in and see how we're doing. And as you said, it was a very holistic approach, and you really did feel like you have those arms around you of people holding you up and loving on you and protecting you and guiding you. But it's just one question, and you were talking about communicating. Is one of the questions was if somebody's in palliative care, how does that team communicate with all the various doctors that our loved one may have?
Yeah, and that's a great question. Oftentimes there are electronic capabilities with the different electronic health systems that providers are using. So there's a lot of exchange of information through those EHRs or EMRs. And then good old fashioned picking up the phone and just communicating with the different other providers to make sure that they're on the same page, because if somebody has had a specialist for quite some time and we have the palliative care team in the place and they're trying to make a decision, the family is, and about what to do about a certain symptom, then it's going to really benefit the patient if that care team representative from our palliative program calls the specialist to say, look, this patient's history better than we do. This is what we're suggesting. What are your thoughts on that? And so it's very important that that communication continue. So we use multiple modalities to make that happen.
Got it. Got it. Um, the other question I have is sometimes, especially when there's many siblings in a family and say it's a parent, and different siblings, and I'm sure you see this all the time, have a sort of a different feeling about how to proceed. And especially if you're dealing with a dementia patient, for instance, or a child that can't speak for themselves. And I guess with having so many different people on this team, they're there to help guide the family to come to a consensus.
Yes, we really, especially our social workers and our chaplains, partnered with our providers. We spend a lot of time talking through those exact challenges because it's hard to get consensus if there's no advance directive. And that's a whole nother webinar that we could have on advance directives and the importance of really putting your wishes onto paper, because that mitigates a lot of those concerns, when it comes down to critical decision making. So, that is an important component of it. And to answer this specific question, our social workers are very well trained to mediate those conversations and help come to a conclusion that can be agreed upon.
Excellent.
But if it's not, we do have an ethical committee. We run significant situations through the ethics committee just to kind of deliberate and make sure that we're doing all we can to support the patient towards their decision that they made for themselves if they were able to.
Great. I have one more question here, and then I think we'll go ahead and sign off. And so if you have more questions, please absolutely email mfairbanks@capitalcaring.org. The last question is, can a patient receive physical therapy while in hospice?
Yes, it is an order that our provider has to write, but it is possible. They just have to look at what the purpose of the physical therapy is. So there are situations where it would be an improvement of the person's symptom or functionality that could enhance their quality of life and be indicated. So yes, it's certainly a question to ask to see if it could be reviewed.
Wow. Great information today, Marcy. Thank you very much. I know everyone that's listened in probably could sit here for another half an hour and listen to you talk. It sounds like you've certainly seen a lot. You've certainly given us a lot of information to think about, to apply to our own personal lives, and also if we're reaching out to help others. So thank you again. Thank you, everybody else, for joining us. And I'm going to let Marcy go so she can keep to her schedule. And I'm going to let you go. And again, I hope to see you on Wednesday, August the 12th. So everybody have a great day, and thank you so much.
Thank you, Carrie. Have a good one.
All right. Thank you. Bye-bye now.
Bye-bye.